Hi, everyone. This week we will be talking about eating and elimination disorders. So in terms of the feeding and eating disorders, first we will start with pica. So pica actually can be essentially co-occurring or assigned in the presence of any of the other eating disorders feeding and eating disorders that we will cover this week. So for a diagnosis of pica, there are four criteria that the individual needs to meet. And this is persistent eating of non-nutritive, non-food substances over a period of at least 1 month. So these are things like paper, couch cushions, chalk. These are some of the more, common food item or non-food items that would be that you would see. So the eating of the non-nutritive, non-food substances is inappropriate to the developmental level of the individual. So this is usually diagnosed at 5 years of age or older. 3 years of age or older to compensate for things like teething, where infants and toddlers would be teething. The third is the eating behavior is not part of a culturally supportive or socially normative practice. So in some populations, this was noted later in the DSM, the eating of earth or other seemingly non-nutritive substances is believed to be of spiritual, medicinal, or other social value. So just really keeping that in mind. And then the last is if the eating behavior occurs in the context of another mental disorder, as we know with intellectual disabilities, such as intellectual developmental disorder, pica is much more common. So that would be the diagnosis. Pica would not be part of the diagnosis if, for example, intellectual developmental disorder is diagnosed and then there is eating of non-food items. Or a medical condition that is sufficiently severe to warrant additional clinical attention. So pica would not be the diagnosis, you would be looking at the medical condition. All right, rumination disorder. So this is the four criteria to meet this diagnosis is a repeated regurgitation of food over a period of at least 1 month. The regurgitated food may be re-chewed, re-swallowed, or spit out. So this should be frequent, occurring at least several times per week, typically daily. So this is a more common frequent occurrence. The repeated regurgitation is not attributable to an associated gastrointestinal or medical condition, such as acid reflux or gastroesophageal reflux. The eating disturbance does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, binge eating disorder, or avoidant restrictive food intake disorder. So this is separate. So if regurgitation of food is happening at the same time as the symptoms of any of these disorders would have the diagnosis, not of rumination, or the diagnosis would be of these four, not rumination. And then as always, with that differential diagnosis, that the symptoms occur in if they occur in the context of another mental disorder or a neurodevelopmental disorder, they are sufficiently severe to warrant additional clinical attention. Therefore, this would not be the diagnosis. And then another thing to keep in mind is that rumination disorder can be episodic or it can occur continuously. So it doesn't need to be something that is continuously happening. It just needs to meet the criteria of at least once a month. So it could be, or I'm not once a month, at least for a month. So episodic could be, a month on, 6 months off, another month on, and then continuous would obviously just be all the time. So then we have avoidant and restrictive food intake disorder. As we read, so, always something to keep in mind with the DSM is to recognize kind of where you stand in your perceptions of the diagnoses. So one of the things that Dr. Francis talks about is a fear in this disorder as really not having enough research to really substantiate its inclusion. So, just something to keep in mind as we know that the DSM is informed by research. So avoidant or restrictive food intake disorder is an eating or feeding disturbance that is manifested by persistent failure to meet appropriate nutritional and or energy needs by at least one of the following. So significant weight loss is experienced, significant nutritional deficiency. This is determined by, medical professional tests, dependence on enteral feeding or oral supplement or oral nutritional supplements. So this could be like a feeding tube or something like this, or, needing supplements to compensate for any nutritional or vitamin deficiency. And then marked interference with psychosocial functioning. So remember that this is differentiated from anorexia nervosa and bulimia nervosa, because this isn't really associated with a fear of gaining weight. This is just an avoidance of particular, or food in general, or particular food. So remember, this is where Dr. Francis says, like, are we potentially pathologizing picky eaters? Where's the line? Second is the disturbance is not better explained by a lack of available food or by any associated culturally sanctioned practices such as religious practice. So, just keeping in mind things, for example, like Lent or what's kosher, what is considered appropriate or inappropriate food within a religious context of what is okay to eat. The eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia nervosa. So in that case, that is where those are differentiated because avoidant restrictive food intake is not associated with fear of gaining weight, or because of, like it says here, disturbance in the way in which one's body weight or shape is experienced. That is not present in avoidant restrictive food intake disorder, but it is in bulimia nervosa and anorexia nervosa. And then the eating disturbance is not attributable to a concurrent medical condition or better explained by another mental disorder. And then a note here is that food avoidance or restriction may also represent a conditioned negative response. So this is where I encourage you to do some screening with the individual of like potentially traumatic eating experiences. So it's a negative response associated with food intake following or in anticipation of an aversive experience like choking, some sort of traumatic investigation, usually involving the gastrointestinal tract, or repeated vomiting. So these could be, in avoidance or prevention of like something, potentially embarrassing happening that has happened in the past. So anorexia nervosa, a screening question here may be, do you feel fat even though other people think you are way too thin? So there are 3 diagnostic criteria here. Restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, or physical health. So significantly low weight is defined as a weight that is less than minimally normal, or for children and adolescents, less than minimally expected. So in order to measure this, we generally use the BMI for adults and BMI percentiles for children and adolescents. And this is also including an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though that individual has a significantly low weight. And the last is a disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of their current low body weight. So there are 2 subtypes of this, but most individuals with binge eating or the purging type, so there's the restricting type and the binge eating purging type. They binge, but also purge through self-induced vomiting or the misuse of laxative diuretics or enemas. But this is differentiated from, well, we'll get to this in a couple of slides, but anorexia nervosa is especially the binge eating purge, or I'm sorry, this is just the purging type. Well, binge eating and purging is both differentiated in anorexia nervosa than bulimia nervosa due to body weight. But some of the purging may be that it's not purging after what would be considered a binge. But even when there's a consumption of small amounts of food. So just know that there can be purging even when a binge didn't happen, which is also in many ways kind of subjective or contextually defined, because as we know, sometimes in like celebrations or something like that, we may eat more than we normally do. So also just make sure when you are screening for what would be considered a binge, that you're really taking context into consideration. So a crossover between the subtypes over the course of a disorder is not uncommon. So you may have, for a period of time restricting anorexia nervosa, for a period of time you may have binge eating and purging. So essentially you should look at what has been happening over the last 3 months. And that will be the most current diagnosis, but you're essentially looking to have the subtype description as opposed to a longitudinal course. So you are kind of going and continuing to screen every 3 months to see like what has the eating behavior been. So also another thing to keep in mind is individuals with anorexia nervosa. It's pretty rare for them to complain about weight loss, since that's, part of the goal. So individuals with anorexia nervosa frequently lack insight into or deny their problem with their eating behaviors and their weight. So here with somebody who is, and usually they're not the ones coming in, it's a family member that's very fearful of their health, their life. So with individuals with anorexia nervosa, it's important to obtain information from family members and other sources to evaluate the history of weight loss and other features of the illness. So with this, the individual may not be the most reliable source of information. And then bulimia nervosa, screening question here: do you often lose control and find yourself consuming a very large amount of food in a very short period of time? So 5 criteria here: recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. So eating in a discrete period of time. So generally we find that it's within a 2-hour period of an amount of food that is definitely larger than what most individuals would eat in a similar period of time under similar circumstances. So again, this is, trying to allude to things like a birthday party, a wedding, a celebration of some sort, where food is generally consumed in larger quantities. And then the second piece of this is a sense of lack of control overeating during the episode. So a feeling like you can't stop or control what or how much you are eating. And then with bulimia nervosa, which is what is differentiated from binge eating disorder, is recurrent inappropriate compensatory behaviors. So these are collectively referred to as purge behavior or purging in order to prevent weight gain. So this could be self-induced vomiting, laxative diuretics, medication, fasting, excessive exercise. These are any of the compensatory behaviors in response to the binge eating. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for a period of 3 months. So again, this is how we are, looking at what might be the evolution or the changing of eating behavior. So we're looking every 3 months. Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during periods of anorexia nervosa. So this is another piece of the differentiation. And then you can have 4 levels of severity: mild, moderate, severe, and extreme. And these are based on the number of compensatory behaviors in a week. So then we have binge eating disorder. So this is recurrent episodes of binge eating. An episode is the same as what is defined in bulimia nervosa. So eating in a discrete period of time, a larger amount than most people would eat in that same period of time under similar circumstances, and then a lack of sense of control. So the second criteria is that the binge eating episodes are associated with 3 or more of the following. So 3 or more of these 5: eating more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, feeling disgusted with oneself, depressed, or very guilty afterward. And so there's also marked distress regarding binge eating, and the binge eating occurs on average at least once a week for a period of 3 months. Finally, the binge eating is not associated with the recurrent use of inappropriate compensatory behavior as in bulimia nervosa, and does not occur exclusively during the course of bulimia nervosa or anorexia nervosa. So this is also has varying degrees of severity based on the number of binge eating episodes per week. So wanting to very explicitly differentiate, so bulimia nervosa seems to have some overlap with anorexia nervosa and binge eating disorder. So I wanted to very clearly outline how these are different. So bulimia nervosa and anorexia nervosa, they are differentiated, as I said, based on body weight. So individuals with bulimia nervosa maintain body weight at or above a minimally normal level, whereas with anorexia nervosa, individuals maintain a significantly low body weight. So that is how the two are differentiated. And then in terms of bulimia nervosa and binge eating disorder, they are both characterized by recurrent binge eating. But in bulimia nervosa, there are recurrent inappropriate compensatory behaviors such as purging or excessive exercising, diuretics, and enemas. So in binge eating, those compensatory behaviors are not present. All right, then moving to elimination disorders, there are 2 of them. Enuresis is the repeated voiding of urine into bed or clothes, whether this is involuntary or intentional. The behavior is clinically significant as manifested by either a frequency of at least twice a week for at least 3 consecutive months, or the presence of clinically significant distress or impairment in social, academic, or other important areas of functioning. So B is one of those 2. Also, the individual has to be at least 5 years of age. So this is, of course, to take into consideration things like potty training, just generally getting in control of one's bowels. And then the behavior is not attributable to the physiological effects of substance, such as a diuretic, an antipsychotic medication, or other medication, or another medical condition. And then enuresis has 3 specifiers. Oops, my bad. 3 specifiers here of nocturnal only, which is the passage of urine only during the nighttime. And then the passage diurnal, which is a passage of urine during waking hours. And then there is a combination of the 2 subtypes. And then finally, encopresis is a repeated passage of feces into inappropriate places, such as in one's clothing or on the floor. And this may be involuntary or intentional. At least one such event occurs each month for at least 3 months. So again, the 3 months is essentially the specifier here. The chronological age is at least 4. So again, considering potty training, again, gaining and maintaining control over bowels. The behavior is not attributable to the physiological effects of a substance like laxatives or other medical condition, except through a mechanism involving constipation. So this, as we know, there are 2 different kinds here where we're specifying with constipation and overflow incontinence, or without constipation and overflow incontinence. So usually with encopresis, there is a intervention to where the assumption is that there's potentially some constipation and then an elimination that is involuntary. So when the passage of feces is involuntary rather than intentional, it is often related to constipation, impaction, and retention with subsequent overflow. The constipation may develop for psychological reasons like anxiety about defecating in a particular place. And it also can be connected to oppositional defiant disorder. But we're talking more about involuntary, whereas with ODD, it's considered more intentional. And then that can lead to an avoidance, again, just like with avoidant eating, it may be something where there has been a traumatic event or something that has happened where now the encopresis, or what would be diagnosed as encopresis, is really meant to prevent another like embarrassing event from happening.